I welcome you to New York. I welcome you to the Harvard Club of New York. I think it's critical that we continue to learn and educate ourselves, and hopefully this will be educational for everybody, and I appreciate your coming to support it and to make me feel that I am, in fact, fighting the right fight here. When it comes to treating brain aneurysms, AVMs, carotid stenosis, we have different techniques in our arsenal for how to treat them. Sometimes the same disease can be treated different ways. And it is natural to believe that making an incision on someone's head or someone's neck or someone's back and doing a traditional dissection may be more maximally invasive than embolizing via a catheter or radiosurgery, giving focused radiation. And so the terminology has come to fruition of minimally invasiveness, but what does it really mean? And has it become an overused expression, and is it accurate? I'm going to stop here at this point to introduce Dr. Mayberg. Dr. Mayberg went to Harvard College and then Mayo Medical School, and then did his neurosurgical training at Massachusetts General Hospital. He was the chief of neurosurgery at the Cleveland Clinic for several years, and he's now the executive director of the Seattle Neuroscience Institute. I did my fellowship with Dr. Mayberg, and it's really been a pleasure getting to know him and to be mentored by him. So he's going to be talking to us today on the regionalization of cerebrovascular care. Thanks for coming, Mark.
What are the issues that drive regionalization of stroke care? One is that stroke centers actually work. And there's a fair amount of data, this is get with the guidelines, showing that when you implement these guidelines, people actually do follow the guidelines. But does that make a difference? Are the outcomes actually better? The answer is yes. There have been a number of publications, meta-analysis and these other ones, population analyses, all of which show very substantial improvement in outcome for stroke centers. So clearly, stroke centers work.
When I was a neurosurgical resident at Mass General, Alex was one of the interventionalists there. He was on staff. And I want to just thank him publicly. When I was told to call him in the middle of the night to do a vasospasm treatment, he was by far the nicest. Alex is currently the chairman of radiology at Boston University. He did his interventional training at Stanford, and then, as I said, he was a staff neurointerventionalist at Mass General for quite a few years. And he's going to talk to us today about the INR architecture and room of the future. I appreciate your coming down, Alex.
So I think we have to talk a little bit about what a compelling future can be. And then I think we have to structure ourselves so we can affect that future and realize it. Have we created systems that allow us, using our interventional rooms, to pipeline data and information, to gather information, and know whether we're behaving according to a set of standards? If there's disagreement about different treatment pathways for certain patients, should we arbitrarily flip coins and decide that today we're going to coil and tomorrow we're going to clip? Or should we take that information and somehow compile databases that are automated so we can learn collectively if there are differences of opinion? Can't we structure our learning more effectively with technology? I submit that we can.
David, as I think you've already heard, I spent 6 months in Seattle training with Dr. Newell. He is not only a very good friend of mine, but I do believe a quintessential vascular neurosurgeon, and is now the chief of neuroscience at the Swedish Neuroscience Institute. He's going to talk to us today on the potential for ultrasound as a treatment modality for stroke and other brain disorders. Thanks so much for coming, Dave.
So ultrasound for medical treatment for other portions of the body has been around for a while, and it can do a number of things. It can deliver energy to tissues, break up blood clots alone and with thrombolytics. And as I mentioned, some of these other applications, toothbrushes, fat lysis, soft tissue tumors, tissue relaxation and physical therapy, cosmetics, lithotripsy for kidney stones. And there's a startup company that can actually ablate the nerves around the renal arteries to combat hypertension. And all these are applications elsewhere in the body. But the three ones that we want to talk about today that have particular relevance to neurosciences include sonothrombolysis for acute stroke, sonothrombolysis for intracerebral hemorrhage, and then MRI detected focused ultrasound for the treatment of a variety of brain lesions.
Our next speaker is Dr. Michael Scott. Dr. Scott went to Williams College and then went to Temple University School of Medicine. His father was a neurosurgeon there as well, so I have that kinship with Dr. Scott. He was a full professor of neurosurgery at Harvard Medical School, and I think he's kind of nationally and internationally known as being the chief of pediatric neurosurgery at Children's Hospital of Boston. We're privileged to have Dr. Scott talk to us today. Thank you.
Thank you, John. And thank you to John Pyle-Spellman also for inviting me to come to talk today. I've learned an incredible amount already from these wonderful talks. They've been terrifically instructive. I think you'll all agree it's been a great morning. I'm going to talk about the surgical treatment of moyamoya disease today. And I thought what I would do in this brief period of time I have is to give an overview of the syndrome itself and talk mainly about the surgical treatment that has evolved, at least for children, and also that we've used for our adult patients that we've treated in Boston at the Children's Hospital and the Brigham and Women's.
Rob is really in the elite end of neurosurgeons who have a tremendous basic science research component, and he's published in Nature and Science and the New England Journal of Medicine. There's a tremendous research side to his career that's very impressive. Anyway, he's going to be talking today on using high-definition fiber tractography to manage brainstem cavernomas. Thanks for coming, Roberto.
The questions with brainstem cavernomas is, should they be treated? If they are, when and how? What approach to take? And that's what I'd like to discuss today. And one of the things that Jonathan started the meeting with is talking about minimally invasive. To me, minimally invasive also means, obviously, there's minimally invasive outside the head, outside the skull, but there's also minimally invasive inside the brain. And to be able to get to the location that you have to get to by really transgressing the least amount of eloquent tissue, to me is a very important definition of what minimally invasive is. And for subcortical lesions, to me the challenge is knowing with certainty where are the eloquent tracts, where are the tracts that might have already been damaged by the pathology or not, and this is something that, again, I will discuss about today. With high-definition fiber tractography, you could look at every voxel and really define the flow of water molecules in much greater detail, and really can provide you a much better map of the fibers within the brain. Again, really looking at greater detail at all the flow. So really transforms something that looks like this into a set of fibers that really you can gain some information and make some decisions.
Okay, we're going to finish up here with a couple more talks and some interesting cases by John Pyle-Spellman.
Here we see this tiny aneurysm, and had a discussion of what to do. And in fact, it looked like on the follow-up angiogram that it was growing. There it is there. It was small there. You can do an occlusion on this. You go out, but the question is, what is it? It was growing. The subdural actually looked like it probably was, certainly wasn't getting any smaller. It might have been growing. And John took her to the OR and got that, and post-op, there we are. So those are two complex distal aneurysms.
On behalf of myself and John Pyle-Spellman, I want to thank everyone for your attention and for your participation.